Okay, we are going to focus on autoimmune disorders, other neuro disorders. Please, please, please just focus on the ones in the slide, and I'm going to try to be as focused as possible on where to pay attention. Okay, so these are the three: multiple sclerosis, myasthenia gravis, and a Guillain-Barré. All right, so multiple sclerosis, progressive immune-related demyelin disease of the CNS. So you'll see in a picture our nerves. They're covered by this gelatinous covering. And basically, what multiple sclerosis does is it breaks that down to where there's no protective layer and the nerve endings end up dying. It is very, very hard to diagnose. This is something you need to know. You have to basically rule everything else out. Part of how a doctor finally realizes this possibly could be a neurodisorder and it could be multiple sclerosis is by the poor patient having to come back explaining the same signs and symptoms, and they've ruled everything else out, such as, they need more sleep because of the complaint of fatigue, possible other issues, diet. So it's not an easy disease to diagnose. Frequently, the disease relapses and remits. It has exacerbations. Not everybody gets it the same. Not everybody has the same debilitating issues as others. Some have it in a very mild form. Some slowly progress over years and can remain independent. Others can progress very quickly, as stated here, in the exacerbation periods and end up having to have total care. It's very sad. Okay, including fatigue, as I stated, weakness, numbness, difficulty in coordination, loss of balance, pain, and visual disturbances. So the management here is by replacing the interferons. It's not a cure. What this does is it tries to slow the progression of the disease for people who are in exacerbation. It treats symptoms. Again, it's not a cure. It decreases muscle spasms, hopefully decreases fatigue, and bowel bladder issues if they are having problems with that with their MS. Here's the picture. So here's our beautiful neuron and our nerves, and here's the sheath. As you see, as it progresses, our protective layer is starting to break down until there's no more, and we will have nerve death. Okay, here is the scan. If you see, it's just this white, thick layers in areas where it doesn't belong that cause the feeling of loss of coordination, loss of movement. Here is the types. So by this table here, the relapsing remitting, increasing disability, you see it's almost, they have increased symptoms and it gets bad, and then nothing. And then they have another round, and then nothing. So then you see here, in primary progressive, it's a progressive, just how it sounds, incline. In secondary progressive, it's hit, they have some time. So, and then here, progressive relapsing, they have moments. So it depends on the patient. And we won't know until they are diagnosed and how quickly they bounce back. So it's not an easy thing to diagnose, and then to figure out the type and how progressive they're going to be is going to be another issue. Okay, myasthenia gravis. So autoimmune affects the myoneural junction. Antibodies directed at acetylcholine and the myonomial junction impair transmission of impulses. Both these diseases affect women more than men. Studies have shown people that have a lot of stress in their life, worry a lot, I think that's every American, right? Are more susceptible to these diseases. Everybody holds their stress differently. Everybody gets upset differently. Some cannot let it out. Some hold everything in. So when that happens, our bodies are affected in different ways. And a lot of those things are causing autoimmune diseases, such as myasthenia gravis. So I just want you to keep those points in mind. All right, so initially symptoms involve ocular muscles, diplopia, impetosis, weakness of facial muscles. So they almost look like they've had a stroke. Swallowing, voice impairment, dysphonia, and generalized weakness. So please understand for this one, we have to rule out a stroke, obviously. This can last for months. All right, so here's your ACH receptors. This is what's affected. Okay, and here is the end plate here. So can you see the difference? We're making plenty. They're responding. It's blocking it now, and it's not allowed to come in, so they don't have enough, and this is the cause. So that's that real short patho in a nutshell. Okay, so directed at improving function and reducing or removing circulating antibodies. You know, some women can be fairly young, middle-aged, so think of body image when you're thinking of this. Think of months of being this way. So medical management, we need to replace what's needed, which would be the acetylcholinesterase, and get that going, and also some IVIG. Plasmapheresis is not one of the first lines, and a thymectomy is probably the more invasive. Usually medication is the way to go. Plasmapheresis, it has to be pretty severe. So I want you to focus on the pharmacological therapy and understand plasmapheresis. So a crisis is just what it sounds like. Results of disease exacerbation, which means it's not in control. They're having severe issues. Generalized weakness, respiratory bulbar. So think about it. We have muscle weakness, muscle loss in the face. Of course, we want to pay attention to make sure that airway's okay, they're breathing okay, and they're not having any issues there. The generalized weakness, patient may develop respiratory failures compromise. So again, please make sure. A cholinergic crisis is too much of the medication. This patient, depending on how long they've been treated and severity, can easily have too much unintentionally. So this needs to really be paid attention to. Caused by over-medication, severe muscle weakness by respiratory, patients may develop respiratory compromise. So both need to watch out for that, cause and treatment. So management of a crisis. So the biggest way to manage a crisis, again, is hopefully to prevent the crisis. If they are in a crisis, obviously, we stated airway is the biggest thing we want to be paying attention to here because of the muscle weakness. If this is the case, ensuring adequate ventilation, intubation if necessary, proper mechanical ventilation, assessment supportive measures to ensure airway and respiratory support, ABGs to be managing electrolytes and blood levels, INO, daily weights. So what do you see here? I want you to take away from this again. Look at everything that has to happen. This patient, you need to start imagining again, is in an ICU setting, multiple different lines, multiple different needs. This patient is going to be 1-to-1 if they are intubated with an airway, 1-to-2 if they are critical with no airway. Look at the many things that need to be done. Sedatives, tranquilizers, cannot swallow, nasogastric feeding tube. So this is critical. If they have another comorbidity or any kind of co-issues, this could be even worse. So I try to get you to imagine that environment to understand the constant monitoring, the constant assessment that needs to be taking place. Okay. So think of myasthenia gravis again. What is the weakness, fatigue, paralysis come in? Is from what? The head, from the top to the bottom. Okay, Guillain-Barré, the weakness, fatigue, paralysis starts from the bottom up. But here's the thing with that. When Guillain-Barré starts and this paralysis and weakness starts from the top, it's fast, it's onset, so an airway issue is still imperative because once it gets here and we lose it, we can't get it back. We unfortunately, either we've lost our airway, we have to put an emergency trach in, it's life-threatening. So you always want to preserve your airway in any instance. Okay, autoimmune. Acute attack, peripheral nerve myelin sheaths again. Rapid demyelation, again, when it starts, you can't, it's like a train wreck. You have to do it. So when I say this to you, all of these are very hard to diagnose. They are not the easiest of diseases to diagnose. So somebody with this usually comes in complaining, you know, I'm weak, I'm tired, I don't feel good, I'm haven't been able to get out of bed, my legs aren't working. They have a lot of weakness in the legs. And by the time it could be diagnosed, it could be too late. We could already be in respiratory distress. So, rapid demyelination may produce respiratory failure, autonomic nerve system dysfunction, and CV instability. Most often follows a viral infection. So one of the biggest questions when somebody says, you know, I'm loss of my leg muscles, leg function, I can't do as much as I was, I'm just not feeling right, I'm tired. One of the biggest questions, have you been sick lately? Usually it's somebody who's recently been sick with the flu. COVID is a virus. This could possibly happen. And it's usually a week or two after the fact. So it has to be a viral infection of some kind. All right. May include weakness, as stated, paralysis, pain, diminished absences, reflexes, starting with lower extremities, progressive and onward, valvular weakness, cranial nerve symptoms, tachycardia, bradycardia, hypertension, and hypotension. Once this starts, this patient is going to be very unstable for quite a long time. It's going to be a lifelong rehabilitation, like a traumatic brain injury, as we were talking about in one of the last chapters. We don't know the recovery. We don't know if they'll be able to walk again, talk again, but the sooner the patient gets going, the sooner the patient tries to walk when approved, sits up in a chair, the more the patient puts into a recovery with any kind of neuro issue, the more they will get out of it. Why I say it that way is because we all think of the situation. We would go through depression, anger. They may not want to get up. They've given up. They're in pain. What for? They're mad. They're in this situation. They don't want to fight as hard as they need to. And actually, it's imperative they do. You can't force somebody to do something if they're not ready. But how can we get through to them? A lot of education with family. A lot of education with the loved one, with the patient. Explaining to them the importance of that. Any kind of neuro injury. And during that rehabilitation phase, usually recovery plateaus at about 6 months. Wherever they are in their recovery at the 6-month point is about where they're going to be. Now, of course, there's those miracles out there. That doesn't mean they're going to stop improving. There still have been known to be some improvements over time, but that's usually that rule of thumb is 6 months. You know, if they're still wheelchair dependent, more than likely they're going to be wheelchair dependent for the rest of their life. So just so you can kind of understand that. When you take care of a patient with a neuro condition, please understand and know it's a long road. When they are in the hospital in critical situations, the way we discuss right now in lecture, that is the acute phase. When they now, remember, these patients aren't going home. They have to learn how to live all over again. They usually have to go to a rehab center. You know, and that's the rehab phase. So this is a lifelong journey for some. Okay. We're done here. Okay. So medical management. It is an emergency, as I stated, requires intensive management, continuous monitoring of respiratory support. Plasmapheresis is one of the big treatments here. So you really need to be aware of it. Like I was saying, IVIG, replacing that immunoglobulin, used to reduce circulating antibodies. Recovery rate varies, as I stated, but most patients recover completely. I had a patient a long time ago, before we get on this slide. He was a big guy. I guess he had a history of meth use. And when his family said he started complaining, he was sleeping a lot and just not moving a lot. He just wasn't acting right. They right away assumed he was using again and something was wrong with him. And actually, when he finally got into the hospital and still the facade of he must be using again, finally left him. He was diagnosed with Guillain-Barré, and after years later, he still has to walk with support. So, it just goes to show you got to really look at every patient individually, and, you know, you take their history into consideration, but you really got to look at the whole picture and not judge, and you got to be as objective as possible. Okay. So here's care of a patient with MS. So some neurodeficits, impact of disease can be debilitating. It's usually physical. It can be social again, because there's a lot of psychosocial with MS. The patient can be fairly young, have a partner. Think of a fairly young woman that's now pooping and peeing on themselves, can't bathe themselves. It's embarrassing. Altered body image is huge. They go through the depression with the loss of body function. And again, it can depend on the severity, but think of that. You know, they lose friends. They now become they have to have the caregiver. They're not the caregiver anymore. So, just like any other neurodisease, it's a family dynamic changes. The person that they loved once is not necessarily the same anymore. So many dynamics change. Please consider that. Okay, here's your biggest diagnosis here. You know, I have stated it in lectures past. This is a good way to study. These are your biggest issues right here. Now, not every patient's going to have the same priority, but these are the main big priorities here you see with this disease process. So please understand them. Please understand that what you would see in an assessment with somebody with this priority. You know, write that down. What would be the interventions for this priority, for this diagnosis? Okay, what would be the priorities? It's important to know these. So when you read the question, you don't just jump to the main one of airway. You read these and you read the question thoroughly and say, the main priority diagnosis for this patient with MS is ineffective coping. Okay, so home maintenance, because again, they're going to have less physical function. Sexual dysfunction, they may have loss of sensation. They're not able to get as aroused as before. Weakness, there's many reasons. Again, there can be some incontinence involved. It's a whole sad change of dynamics. Okay, so planning. Here's some of your planning for that. Lots of rest. They shouldn't be out in the sunlight. They should cluster their activities before they get very fatigued. Okay, promotion of speech and swallowing. Any kind of brain injury, any kind of brain debilitating disease, keeping the brain exercise is key. This is one of those least invasive interventions that you could do for any of them, which means what? Reading, puzzles, keeping busy, artwork, things like that help a lot to strengthen cognitive function and keep cognitive function, okay? We can do some bowel and bladder training if exacerbation is over, at least to prevent some of the incontinence or, you know, eradicate it altogether. The coping of this issue. Let's see. I think we went over the rest of these. Because of the fatigue, they have more of a high risk of falling, less control over muscles. So big fall risk here. Okay, collaborative approach. If somebody's whole life is altered and changed, we're going to need that collaborative approach. We're going to need PT. We're going to need OT. We're going to need case management to come in and offer these resources that are available in their community, not just for them, but for their families as well. I mean, the whole dynamic is going to change. I don't know if any of you saw or remember from your first semester, you will see, unfortunately, in every long-term care facility in town, there's always this fairly young person that has MS in the facilities because their families are not able to take care of them anymore. It's very sad. Okay, PT, OT, home care, activity, and rest. One of the biggest things here is understanding their body again. You know, making sure they're using their body by moving and walking when it's able and it's safe, but also to not get too fatigued and too stressed, to understand their limits. Avoid serious strenuous activities and extreme fatigue, as stated. Okay, for bowel and bladder irrigation, again, it's that same kind of bowel and bladder training as I was talking about brain injury. Just get them up every hour, every 2 hours, every 4 hours. Okay, we need to assess that. Swallowing, if there's weakness in muscle there to prevent any kind of aspiration. Memory aid, again, the more the body does something and the more a muscle is used, it becomes easier and it becomes a memory over time. A daily routine for a patient trying to learn how to use and control their body in this new environment over again is huge, huge here. Okay, avoiding constipation is big. You know, a lot of fiber in their diet, stool softeners, things like that. Change of this diet. So minimize stress. Again, a lot of these are autoimmune. More stress, more worry can cause any of these diseases to exacerbate. So please, please, please be aware of that, okay? Temperament environment, calm environment. If they have, unfortunately, a family member they argue with frequently on occasion, if their spouse comes in and they're always upset, this could be something that needs to be discussed. And so it's not just stress of a relationship, it's stress of the environment as well. You know, we've talked about decreasing stimuli, not having too much noise. It can also be overheat, exhaustion. It can be just anything that you or I could cope with on a daily basis that affects us, but we can handle it. Such as, you know, the temperature, air conditioning to avoid excessive heat, assist devices and modifications, especially on if they're weak on one side, just to have that safety issue and prevent that muscle from getting too fatigued too soon. That also promotes more independence. If they can use some kind of cane, and this could give them more independence around the house and actually on outings, you know, this can do a lot for, whoa. So for the nursing process for Guillain-Barré, an ongoing assessment. Again, this patient is in an ICU. This is a life-threatening issue. It will eventually affect the airway. Our goal is to protect the airway, maintain comfort for this patient, and allow them to rest while they battle this. Issues, I mean, you got to think, again, if you consider an ICU environment and they're vented and they are completely sedated and in our care, you have to take care and consider every body system. We keep talking about respiratory. How about cardiac? How about GI? It is our role and our job to make sure that their body is at optimal function when they recover and come out of this. So getting the proper nutrition, possibly placing an NG for that. You know, protecting their gut health from the bacteria in there is big. You know, usually rule of thumb is about 4 or 5 days to start some kind of nutrition there. Skin integrity, perfusion issues, maintaining that optimal blood pressure, getting that bed that turns them, flips them. We have to turn them. Protecting those bony prominences, those range of motion, that muscle movement. You know, many of these things, preventing those DVTs from happening. Okay. Assess vital signs frequently, continuously including continuous ECGs. Again, continuous monitoring, continuous lines of everything, labs and all. And again, family coping, them just understanding, don't give false hope in these areas. You know, we're doing the best we can. He looks good today. Today's a good day. He's been tired today. You know, a little aggravated today. You know, is this going to change? Is this going to be forever? Is it a cure? You don't know. And you can't tell them. And, you know, just be honest with that. You know? Okay. So here's your main diagnosis for Guillain-Barré. Again, I would use these to study and make a plan of care for them. Okay, some collaborative problems and complications, respiratory failure, so autonomic dysfunction. They could lose thermoregulation. They could lose movement permanently. They could lose a loss of controlling of blood pressure, perfusion. Again, this could be a whole paralysis. Unfortunately, DVT, PE, urinary retention. Again, as this paralysis and this issue rises, they are losing function and they are losing sensation. Okay, so the care of the patient, some major goals. Here's your goals here. Again, they're the same diagnosis as now we need to fix them, protect them, prevent them, decrease them, however you want to think of this. So enhance physical mobility as much as we can, those range of motions, possibly a chair if possible, those beds that sit up into a chair, movement. Range of motion is the biggest thing here until they can do anything for themselves. Frequent position changes, elastic compression hoses, SEDs, adequate hydration, constant hydration checking, constant urine checking, constant electrolyte checking for anybody in a critical care unit. And that even goes in a med-surg floor, but I really stress in a critical care unit as well. Careful assess of swallowing and gag reflex. If we're talking muscle weakness, paralysis, these are huge. These are the same signs and symptoms we are seeing over and over again with these neuro disorders. Okay, so this needs to start coming second nature to you as what you're going to be doing for interventions and what you're going to be looking at. So a plan for communication for individuals and patient needs. Fear, anxiety. Is this their new normal? Is this their new life? What am I going to do? Who's going to take care of me? Am I going to be a burden to my family? The same worries and the same fears. Maintain positive attitude and atmosphere to promote sense of well-being, diversional activity.